before administering any fluids. And also for others, the institutional guidelines and the scope of practice will determine how you continue with your fluid resuscitation. So we are going to cover the following areas: understanding the basics of fluid resuscitation, the role of IV fluid administration, fluid compartments, review of the basics of various fluid options, normal plasma electrolyte composition, types of IV fluids, and lastly, we will also discuss concerns about fluid management. And please, as we discuss here, or as I put here, if you feel like there's a question, may I humbly request that you wait until the presentation so that we can be able to have we can have time for discussion and questions. So, bearing in mind that the role of the IV fluid administration is to provide volume replacement, administer medications, electrolytes, blood products, and also administer diagnostic agents. We also provide, or we can also provide fluids for maintenance and correction of nutritional status of different individuals. So let us remember that there are three fluid compartments, but basically there are two. There is intracellular fluid, which is comprised of the 60% of total body human fluid or water, and the extracellular fluid, which is subdivided into interstitial fluid and intravascular fluid. So the fractions of that we need to remember of this fluid that I have already talked about, particularly if you are taking a book person, being the 80 or 70 kg male person. The total body weight or body water is 42 liters, and the 2/3 of this body weight, this comprises 2/3 of body weight, and intracellular fluid is about 28 liters of the total body weight, which also forms 2/3 of the total body water. The extracellular fluid is only 14 liters, which is 1/3 of the total body water, and the interstitial fluid is 10.5 liters, which is 3/4 of the extracellular fluid, and the intracellular fluid is 3.5 liters, which is simply or only 1/4 of the extracellular fluid. So this fluid that we have been talking about, its main mechanism of transportation through these compartments is through cell membrane, which has two characteristics, or which has two types, being the first one being the non-brain capillary endothelium, which is permeable to everything but colloid. Therefore, only colloids are osmotically active at the non-brain capillary membrane. And the second one is the brain capillary endothelium, which is the blood-brain barrier, and it is only permeable to water. Therefore, all anions, sugars, large molecules are osmotically active at the cell membrane and the blood-brain barrier. So how are our fluids regulated in our body? Mainly, the fluids are regulated through fluid intake, hormonal, and fluid output. So fluid intake is comprised of being thirsty and taking water in, and the requirement is probably can take up to 3 liters per day, or 200 to 2,700 milliliters per day. Hormonal, we have the antidiuretic hormone, which prevents loss of sodium. We have the renin-angiotensin-aldosterone mechanism, which is able to convert the angiotensin 1 into angiotensin 2. thus helping to conserve water. And atrial natriuretic peptide hormone, which also good in losing or helping to lose water from the body. And we also have the fluid output mechanism, where the fluid is lost through kidneys, skin, lungs, and the gastrointestinal tract. And this can be either sensible loss or insensible loss, as it is indicated from each of the systems. So the normal plasma electrolyte composition is as follows. We have sodium, potassium, calcium, magnesium, osmolarity, and under the anions we have the chloride, phosphate, sulfate, organic acids, and the protein. So I'm sorry I didn't indicate that the sodiums and potassiums are the cations, but I'm sure you are aware of that. So the types of fluids that we have, we may have different forms, but they are categorized into crystalloids, colloids, and blood products. The crystalloids are the fluids that we normally or are in common use in our settings, and this can pass through a semi-permeable membrane. Let me just highlight that the crystalloids, normally I say these are, as the name probably indicates, crystalloids, the ones that are clear when you look at them with your own naked eye. The colloids contain solids in the form of large protein and other similar-sized molecules. They cannot pass through the walls of the capillaries, and they attract water from the cells into the blood vessels. Therefore, they remain in the blood vessels. Blood products, it is clearly indicated that there are different forms of blood products. It can be either whole blood, red blood, concentrated blood red blood cells, or plasma. So with the crystalloids, we have either the hypertonic, hypotonic, or isotonic solutions. So with the hypertonic solutions, they draw fluid into the intravascular and from the cells and the interstitial compartments that they remain. That means they remain in the interstitial compartment, and their osmolarity is higher than serum osmolarity. The hypotonic solutions, they shift fluid out of the intravascular compartment, hydrating the cells and the interstitial compartment. Their osmolarity is lower than the serum osmolarity. Isotonic solutions, because an isotonic solution stays in the intravascular space, expands the intravascular compartment, and osmolarity is the same as the serum osmolarity. So let's come to their use. The common crystalloids that we have in our settings, we have dextrose 5% in water, which is isotonic and can be used for fluid loss, dehydration, and hypernatremia. We also have 0.9% sodium chloride. They normally call it normal saline. It is also isotonic, can be used in shock, hyponatremia, blood transfusion, resuscitation, fluid challenges, diabetic ketoacidosis. Lactate dringers or Hartmann's solution, it is also isotonic, can be used in dehydration, burns, lower gastrointestinal fluid loss, acute blood loss, hypovolemia due to fat spacing. And we also have 0.45% sodium chloride, which is half-strength normal saline, which is hypotonic. And it is also used for water replacement, DKA, gastric fluid loss from the gastrointestinal and or vomiting. We also have dextrose 5% in half normal saline, which is hypertonic. It can be used in later stage of diabetic ketoacidosis. Dextrose 5% in normal saline, which is hypertonic, can be used temporarily for treatment from shock if plasma expanders aren't available or in Addison's crisis. And we also have dextrose 10% in water, which is hypertonic. It can be used for water replacement conditions where some nutrition with glucose is required. And most of these crystalloids are used as additives for administration of or dilution of certain medications or intravenous medications. The colloids that we have that are in common use, even though we may still have other colloids that are not mentioned here, similar with the crystalloids. We have albumin, which has a plasma protein of 4% or 20%, and it keeps fluids in the vessels, maintains volume, and primarily used for to replace protein and treatment of shock. Dextran or polysaccharide, which is 40 or 70, and it is used for shifting fluids into the vessels, vascular expansion, and it prolongs hemodynamic response when given with heterostash. The heterostash is also used in fluids to shift fluids into the vessels. That means it is a vascular expander or volume expander. Mannitol or alcohol in sugar, 5% or 10%. It is used in oliguric diuresis. It reduces cerebral edema and eliminates toxins. So blood and blood products. With blood or blood products, we have plasma, red blood cells, white blood cell concentrate. We also have the platelets, and they are used for different reasons, but all in all, I'm not sure. I'm getting a signal that my internet connection is unstable. I'm not sure if you can still clearly hear my presentation.
I can hear you and see the presentation.
Thank you very much. So with blood products, it all depends on the clinical condition of the patient, and they are used in for different reasons for such patients. So now let's take a scenario of this fluids that we have, where we will need to give a patient a fluid of 1,000 ml or 1 liter. That means if you decide to give dextrose 5%, that means 660 milliliters will be in the intracellular space, while 340 of mLs will be in the extracellular volume or space, and 255 will go into of that. It will go of that extracellular compartment will go into the interstitial space, and only plasma volume will be 85 mLs. That means the whole of the sugar will be taken out. Normal saline or Ringer's lactate, it will pull 100 mLs into from the extracellular space into the extracellular space, making it to 1,100. Then the interstitial volume will be 825, while the one that remains in the plasma volume or increasing the blood volume will be only 275. If you use albumin, there will be the total of 100 mLs, or the whole 1 liter will go into the extracellular space, while from that extracellular space, interstitial will be 500 mLs and plasma will be 500 mLs. That is 50-50. And if you use a whole blood, the whole 1 liter will remain in the extracellular space and none will go into the interstitial volume, while 1,000 or 1 liter will go into the plasma volume. So having said this, or having made these considerations, which volume or which solution are you using for resuscitation? Crystalloids or colloids? One, there is a lot of controversy that exists over the use of colloids or hypertonic solutions as a resuscitative fluids. Why? Because the large volumes of crystalloids, sometimes necessary for stabilization of the resuscitation and stabilization of the patients, may lead to peripheral edema that may hinder wound healing. While with colloids, the colloids will offer the theoretical advantage of expanding the extracellular space with less volume, and they have been used to increase blood pressure more rapidly than the crystalloids. That means if we make an example of 1 liter of dextran, it increases extravascular volume by 800 mLs, and that of hetastarch by 750 mLs. That of albumin, it will only be by 500 mLs, and 1 liter of normal saline, it will only be by 180 mLs. So, considering all this, we should also look into the fact that colloids may inhibit the coagulation system and may have colloidal anaphylactic reactions, and they increase risk, or they have the increased risk of acute renal failure, which also may give resuscitation, or if they are given for resuscitation or sepsis, which is due to inadequate free water replacement. The overall meta-analysis of intravascular fluid therapy and mortality are not supported, or are supported as a benefit for colloids over the crystalloids. But several meta-analyses have shown that trend towards increased mortality in heterogeneous groups of crystalloids patients are resuscitated with critical patients resuscitated with crystalloids is increased. However, given the available data and potential risks, solutions of given the available data and potential risks of the solutions, crystalloids still remain the cornerstone, or the corner fluids for volume resuscitation, although patients with profound deficits may benefit from colloids in addition to crystalloids. So the other thing that we need to indicate is that with the use of the colloids, I'm not sure if I did indicate that, particularly when you are going to administer blood, you need to be very much conscious, because the colloids may cause some form of coagulation reactions. So for references, we may look into these different references that I have used to develop these slides. And having said this, you are welcome to have comments, questions, and any views that we can share. Thank you.
Thank you very much, sir.
Thank you.
At this point, we'll be asking if anybody has comments, questions, additions, subtractions to what he's already done. We invite questions, please.
In the absence of questions, let me also re-highlight that, as I indicated, you will note that we have only touched the basics of fluid resuscitation. We did not go into particular details. Or there is a hand there. Sylvia?
Thank you, sir, for the presentation. It was a nice one and so informative. I really don't have a question, but I just wanted to thank you.
Thank you very much, Sylvia. Or before Sylvia raised her hand, I was actually indicating that this was just the basics, just things to remember or to put in mind when we administer fluids for resuscitation or for maintenance.
Right. Thank you very much, Kutoane. We are grateful you made time to share with us today. Just to remind everybody that this is an ongoing webinar for emergency nurses across Africa. Next month we'll be having that of our next month title webinar will be on burns. Hopefully, we'll send out the link again for individuals to register and make themselves available for this. Also, remember that in November we have our AFEM, African Federation for Emergency Medicine, holding a conference in Ghana in November, and we want to entreat each and every one of you, if you can afford to attend. We invite all of you to be present in Ghana. It's going to be nice to put faces to some of the names that we have here on this platform. And also watch out for some news updates on our platform. WHO, under the leadership of the the Chief Nursing Officer, has put together a platform for emergency nurses and critical nurses as well as midwives. And the idea is to put us all on the same platform to share ideas and to learn from experts in those areas. We'll be sharing the platform for those of you who are not already on the platform, so that we find a way to consolidate our gains as Africans and also to move on together and share ideas. On this note, since we do not have any further comments and questions from you all.
Before you close, Atiapong, sorry. Emmanuel, can I also add to what you have just said? That also this presentation and the previous presentations, the participants, they can get them from the website of the African Federation of Emergency Medicine, AFEM.Africa. And there are many other resources there that they can find for continuous learning. Thank you. That is just what I wanted to add.
Very well, thank you. Yes, they will be on the AFEM.
I have some question.
Very well, please go ahead.
I would like to know, is the Superdale still standing? I saw AFEM release the Superdale. My passport is not yet out, and I had wanted to apply for Superdale. Is it still there?
Sylvia, yes, we are still working on that. We continue to impress on individuals who are registering to also make a bit of donation towards Superdale. So once we're able to do that, I'm sure individuals who have applied for will be contacted, and they will screen you based on your eligibility criteria that is put up on for Superdale. So please look out for it, and we will contact you when that is done.
When is it ending? When is it ending? When is the deadline to apply?
I mean, registration is still ongoing. So once registration is still ongoing, we expect that at least we are able to make some gains on that aspect. So if you haven't done that, please go ahead and do that. Apply for it.
Okay. Thank you, sir.
All right. On this note, thank you so much for joining. We hope to see you again next month, same time, and have a wonderful day. Thank you.